74 سنة, old male smoker, 30 big year smoking history, FEV1 40% has successfully reduced his smoking habit to only 3 cigarettes per day with help from smoking cessation service. However, he can only walk 100 meters at a time before he becomes out of breath, feels that he needs to stop. His medication include inhaled long-acting beta agonist وتايتروبيوم. On examination, BB 155/85, and he has coarse crickles and wheeze throughout both lung field. COPD.
COPD.
تمام. ال HB عنده HB كويس شوية 12. WBC كويس. البليتلت كويس. الصوديوم بوتاسيوم كرياتينين ريزد الكرياتينين 139. البايكارب 30. البي اتش 7.4. البارشل بريشر أكسجين 10 كويس. لا نازل شوية. البارشل بريشر كربونيك دايوكسيد 6.4 raised which would best improve which would best improve his exercise tolerance.
exercise tolerance هيموجلوبينه كويس. ماشي.
الريهاب
rehabilitation.
rehabilitation.
بس هو بيستخدم inhaler beta long acting beta agonist and tiotropium.
ايوه هلا وفي النهايه هو عايز الشورت الحاجه اللي بتعمل امبروف الاكسرسايز توليرنس.
ريهابيليتيشن البورتابل اكسجين مش هي اكسرسايز توليرنس مع البورتابل.
اوكي تمام.
طيب في حاجه في اختيار تاني
اصلا الانديكيشن لسه اكسجين لسه
سموكينج سيسيشن.
smoking cessation.
هي دي سموكينج صح؟
ما هو نزل البروجرام صح؟ هو نزل اوريدي نزل البروجرام سيسيشن.
نازل. هو قلل السموكينج سيجرت تبعه الى 3 سيجرت. اوكي تمام.
يعني قصدك ان هو اوريدي عمل كده
في السيناريو
3 سيجرت بير دي. تمام.
هو اوريدي بدل البروجرام لو ما كان ذكر البروجرام يعني كان ممكن نقول السموكينج يعني.
Pulmonary rehabilitation, given his limited smoking habit, it is likely that pulmonary rehabilitation program will have
زي ما انتوا فسرتوها فعلا. تمام رائع. طيب شوف
شوف السؤال.
اوكي سؤال فيه اكس راي وانفيزيما شكلها ولا لا؟ سوري انفيزيمة ايه؟
pulmonary edema. What's the following help diagnosis.
طيب خلينا نشوف finding بتاعته.
First the expiratory volume 1 second 70. ماشي مع restrict.
restrict تمام.
هايبوكسيا شوية.
هايبوكسيا شوية صح تمام.
56 سنة, man referred to the outpatient department with 2 years history, increasing breathlessness and deteriorating exercise tolerance. He has non-productive cough and always feels tired, so much so that he needs to ask his wife to help him look after his bygone, which he has been rising for many years. Over the last year, he has lost about 1 stone in weight. He has post-medical history asthma as a child. In his social history, he has had no history recent foreign travel except to France. He has always worked in bank and an ex-smoker who drinks many amount alcohol. On examination, he is not clubbed. Auscultation chest, inspiratory crickles. ماشية مع
باشنز دي بيستيكوز
بستيكوزز بتاعت البايجون.
بيستيكاو
بستيساي بس هو المرض اسمه بستيكوزز صح؟
بيستيكوزس
extrinsic
اللي هو الافيان سيرم
avian precipitants.
طلعت مش البستيكوزز دي اللي هي بتاعت
ما هي بالبيج
البيجونز
البيجونز دي حاجات اللي هو تبع
اسمها ايه بقى؟ اكسترنسك نومونايتس ولا كان اسمها
allergic extrinsic allergic alveolitis.
الفولايتس
هي بتيجي بالأبر مش باللور. الأبر
الفولايتس اكسترنسك الرجيك الفولايتس
اللي هي البيرد فانسر لانج.
كان بتيجي فين في اللور؟
أبر
بالأبر
أبر
بس
هي اكستنسيف حتكون
تعبانة شوية.
أبر ولور كل
ماشي.
تمام. The patient has interstitial lung disease demonstrated by slowly progression, shortness of breath, type 1 hypoxia, and restrictive lung function test, reduced TLCO and KCO. The chest radiography show reticulorendular shadowing. Diagnosis extrinsic allergic alveolitis, secondary to bygons, Barrett Fencer's lung. This is caused by inhaled avian serum protein, usually IgA, present in the bygons, features, and excrete. It is hypersensitivity pneumonitis caused by specific immunological response to inhaled organic dusts. Extrinsic allergic alveolitis may present either acute or chronic. Acute develop several hours after exposure to high concentration of allergens, breathlessness, and flu-like symptoms. Occur sometimes with headache, fever, myalgia. Symptoms usually resolve within 48 hours. The patient has a chronic disease as he has progressed to interstitial lung disease with fibrosis. A diagnosis of extrinsic allergic alveolitis made by identify the potential source of antigen. Characteristic clinical features, this patient has a chronic extrinsic allergic alveolitis and present with similar features to pulmonary fibrosis. Clubbing tend to be occur later. Idiopathic pulmonary fibrosis is usually typical associated with the clubbing. Characteristic radiology usually in the upper lobe fibrosis. Lung function هتكون restrictive or reduce carbonic monoxide gas transfer. Demonstrating precipitate antibodies, precipitants, and the patient's serum. Resolution or improvement of the symptoms following avoidance of exposure to the cause. Histology of lung tissue biopsy show mononuclear cell infiltration with formation non-caseating granuloma. Fluid obtained من bronchoalveolar lavage, high lymphocyte count, typical more than 40%. Treatment, avoidance the antigen. Corticosteroid may improve recovery in acute attack, but don't seem to provide long-term benefit. They are not usually helpful once fibrosis has occurred. يعني corticosteroid في الأكيوت بس extrinsic allergic alveolitis. Other causes الextrinsic allergic هي الفارمر lung due to micropolyspora, fana and thermoactinomyces in moldy hay, straw and grain. Bagosis due to thermoactinomyces in sugar cane processing, والmalt workers lung due to Aspergillus claftis, والmushrooms work lungs due to thermophilic actinomyces, ventilation and water-related contamination due to thermophilic actinomyces contaminating air conditions system. Veterinary workers and animal handlers, workers in milling and constriction, wood dust pneumonitis due to alternator species.
عدت علينا موضوع الأبر والكلام ده.
تمام. Which of the following is most likely cause abnormal lung function? Forced expiratory 1 second low. هو الريشيو طالع restrictive 88.
الاثنين الكوفيشنت برضه قليل والتلكو قليل، يبقى حاجة ضربة اللنج نفسها. طيب نشوف الكيس.
49 سنة male head teacher present with progressive shortness of breath on exertion for the last 6 months. He has also suffered from joint pain over the last few months and erythematous rash affecting sun-exposed areas during summer months. He has previously been fit, had no medical consultation for 25 years, does not smoke. On examination BB 155/82 البلس كويس، البي ام اي 22 عنده occasional crickles on auscultation, full blood count and renal function are within normal limits. Autoantibodies are positive for anti-nuclear antibodies. السلي
أنا بوزيتيف SLE. هسه حتكون interstitial.
أنا هيبقى joint وراش SLE صح؟
interstitial lung حقت SLE.
The results show reduced lung volume and the normal forced expiratory volume to vital capacity ratio. Impaired gas transfer. Diagnosis: interstitial lung disease, which most common in this age group are idiopathic fibrosis alveolitis, fibrosing alveoli secondary to connective tissue disease, sarcoidosis, and pneumoconiosis. Spirometry show reduced lung volume ratio أكثر من 75%, gas transfer impaired, history polyarteritis, food sensitivity positive. أنا fit best with diagnosis SLE. تسعين سنة. Okay. What is the likely cause? Suspected diagnosis.
restrictive برضه. فيبروز شكله. طيب نشوف الحالة.
90 سنة man referred to the clinic with history progressive shortness of breath and dry cough. 18 months ago, he has able to complete full round of golf. He has now stopped playing as the breathlessness after walking 200 meters. He had been heavy smoker all his life. He has no known asbestos exposure. On examination, breathless at rest, photosensitive rash on his face, neck. He is not clubbed, pulse irregular. Auscultation, his history fail fine, inspiratory crickles, bibasal.
من السيناريو كده أمايدرون.
هي AF وبتاخد أميدرون.
والفوتوسنسيتيف رش نشوف.
TSH طالعة 7.
برضه هايبوثيروديزم.
أيوه خلاص هو الأمايدرون معنا.
أميدرون صح.
The man has interstitial lung disease, gradual onset of shortness or breath and dry cough, not clubbed, but this could well be features, has fine respiratory crickles, lung function are restrictive, type 1 respiratory failure. Chest X-ray show small lung-filled reticulonodular shadowing. Next, you have to look for cause. He has photosensitivity, rash on face, atrial fibrillation, abnormal thyroid function, suggesting that he is on amiodarone. Interstitial lung disease is an important side effect of long-term amiodarone administration. Other side effect amiodarone, hypothyroidism, peripheral sensory neuropathy, hepatitis positivity, ataxia, coronary microdeposit, reversible, metallic test, arrhythmia, torsade de bois, pulmonary fibrosis. Diagnosis is made by combination clinical finding, lung function test, chest X-ray, bronchoalveolar lavage, high resolution CT, VITS, or open lung biopsy in the patient fit to undergo the procedure. If there was no obvious cause for interstitial lung disease and radiology, the biopsy histology will consist with usually interstitial pneumonitis. Then idiopathic pulmonary fibrosis would be the most likely diagnosis. Drug هنا حكي على drugs that cause interstitial lung disease. Antibiotics زي النيتروفرونتوين، في الكارديوفاسكولار زي الأومودارون والبيتا بلوكر. كيموثيرابيوتيك زي البليوميسين والبوسلفان والسايكلوفوسفامايد والكارموستان والكيميتوتريكسيت مالفلان. sulfasalazine, 5-fluorouracil, drug used to treat rheumatoid arthritis, sulfasalazine, penicillamine, cyclophosphamide, methotrexate, gold, a drug used to treat migraine, like ergotamine, ergoids, methylsergide, others like bromocriptine, radiation, dimethiopene, pesticides, high flow oxygen.
معلش عايز اطلع على الكيس. هي انتوا الاميودارون من اللاب ولا في حاجه كانت كلينيكال تقول انه ممكن يكون اميودارون؟
هو AF irregular وعنده photosensitivity, one of side effect أمودارون، وعندك TSH.
TSH لا انا قصدي على في فوق في الكيس، بس الريجولار دي صح؟ سايد افكت
والراش
والفوتوسنسيتيفيتي راش. تمام. اوكيشن. طيب السؤال
How would you control his arrhythmia? This arrhythmia you reassure. نبدأ من فوق
ماشي
أحسن.
ماشي اوكي.
56 سنة old lady comes into emergency department with palpitation, shortness of breath. She is known to have mild COPD and is on following inhalers, salbutamol, bupropion bromide, beclomethasone. According to her notes, she does have mild degree reversibility. On examination, patient's dyspneic, blood pressure 154 على 88, pulse rate أكتر من 100. AF, she underwent echocardiograph 6 months ago. and which show normal ventricular function, no structure abnormality.
نص فليك.
اوكي، عندك شوية هايبوكسيا والبيكارب طالع شوية، بيكربونات 28 كويس. You start the patient 28 oxygen nebulizer salbutamol, ibuprofen bromide, and repeated blood gases after 30 minutes. pH 7.36 كويس، والأكسجين أحسن، ارتفع شوية، والبي سي او 2 5 تمام كويس، والبايكارب 29 كويس. You are reassured here that she is improving on current medication, but she tells you that she is still having palpitation. Okay, Matt. الريت 118.
رأيكم؟
الفيرابامين هو الميتوبرولول ده عشان الأوستيو بي دي سي شوك البيشن ستيبل هو
كالسيوم هو ستيبل، فمش هنروح للدي سي.
والميتابرولول ده عشان السي او بي دي لأ. هو اوكي.
Verbimel. Met commonly occur in critical ill patient with COPD who may be hypoxic or hypercapnic. It is characteristic by at least 3 different B wave morphological with varying PB or BR interval. Aim to improve both oxygen and CO2, whilst AF control may not be required as the pulmonary state improves. It is likely that in the acute phase, especially with repeated salbutamol inhaler nebulizer, that she will suffer from worsening symptoms of tachycardia. As such, Verbimel would be an appropriate option. It can be given a small bolus 5 mg intravenous, then an oral dose 40 إلى 120 ملغ 3 مرات. It is moot point whether she will require long-term AF control. If the following acute episode she remain in sinus rhythm, 72 hours ECG monitor may be appropriate prior to committing her to new medication. Which of the following represent the most appropriate next step for this patient? 64 سنة women referred with worsening COPD, has a 10 back year smoking history. Her exercise tolerance has been steadily decreasing due to dyspnea. She is only able to walk short distance on the flat now. She has previously responded to oral prednisolone with around 25% improvement in her forced expiratory volume in 1 second. Forced expiratory volume 38%. She has tried PRN salbutamol, but this has not helped. يعني استخدمت السلبوتامول بس.
وهي عندها previous response يعني معناها
للبريدنسيلون.
بالضبط. هي سي
ودي سيفير 38 الفورست اكسبيراتوري فوليوم.
تبدأ الستيرويد واللعبة ولا هي كنا بندي لعبة ومعها ستيرويد صح؟ خصوصا إن هي بوزيتيف تيستينج يعني الستيرويد يعني
صح؟
هي ريسبوندر 25 امبروف.
طيب الريسبونتر يبقى لابا و اي سي اس.
هي مش كانت كده صح؟ ولا؟
The patient has severe COPD. A recent study have demonstrated that high-dose combination therapy with fluticasone and long LABA may slow deterioration in forced expiratory volume. Low-dose fluticasone, beclomethasone, abitropium, and Ventolin have no impact on deterioration of the lung function. Study reduction exacerbation with respect diol LABA and inhaled steroid therapy. It did, however, show that the risk of pneumonia was increased in the treated group. Current NICE guidance state that for patients with forced expiratory أقل من 50% اللابا and LAMA as a combination therapy is the intervention of the choice, except as here when there is evidence of a previous reversibility when a patient have been treated with corticosteroid in the past. هنا بندخل ال inhaled corticosteroid. Which of the following is the next most appropriate intervention? عندك ال pH acidosis, ال PCO, البيكارب high, ال PCO2 12 high, respiratory acidosis. Okay. 67 سنة man long-standing COPD comes to the emergency department with exacerbation. He has suffered from severe cough for the past 3 days, productive only small amount, fixed sputum, only able to walk 2 to 3 yards to the toilet. He had 6 admission over the past 18 months because exacerbation. Home oxygen, and he has home oxygen and take nebulizer, fluticasone and salmeterol and tiotropium. When you review him, he is asleep, respiratory rate 15, he mumbles incoherent after vigorous sternal rub. blood pressure 124/82, البلس كويس, polyphonic wheeze on auscultation, chest, ankle swelling, consists with right side heart failure. He receiving 60% oxygen by mask. ده مفروض non-invasive. non-invasive.
ايوه صح.
الريتين ده اللي مش بينقصوا لهم الأكسجين.
ريتينر اللي هم الاكسجين على كام؟ 60.
60 هو بياخد 60 كان. ما هو الفكرة إنه عندنا الكربون دايوكسيد هاي يعني.
الأكسجين للريسبيراتوري بروسيس
هم كانوا تبرين داون الأكسجين تقريبا وبعدين intubation.
صح.
This patient is adequately oxygenated but is clearly drowsy and acidotic because of marked carbonic dioxide retention. The most appropriate next step is to reduce inspired oxygen and recheck the ABG result. It is likely carbon dioxide will reduce significantly, accompanied by a small reduction in oxygen and consequent improvement in the consciousness.
دي الخطوة اللي بعديها.
النون انفيزيف ده هو مش دراوزي يعني تقريبا هو داخل على مرحلة loss of consciousness يعني ما بعرف لو
لا بس هو
هو خلاص.
كاتب لك إن دي الخطوة اللي بعد دي لو ما استجابش آه،
اوكي معاك بس هو لو ايوه
يعتبر
هو
زي
ماشي ديتورينيتد يعني لو بقى خلاص يعني كوماتوز او loss of consciousness مع البي اتش ده ف better to intubate صح. ما هو ده إلا يكون هو conscious يعني عشان أنا
أيوه
أعمل
أيوه.
له
أنا معاكي برضه في القصة دي فعلا.
مم.
difficult question.
Which of the following would be the best initial management for this patient? ال pH شوية high الكالوسيس والأكسجين high شوية كويس الأكسجين
كويس.
بايكاس
إيه، ماشي مع respiratory alkalosis.
يعني الCO2
والبفار 150
ال CO2 في اللور صح؟ في اللور ليميت.
وجد يعني respiratory rate قد إيه؟ 30. طيب نقرأ السؤال.
31 سنة asthmatic woman seen in the respiratory outpatient clinic. She said she had been generally well, although she had not been sleeping well at night due to coughing. She had also noticed that when playing tennis, she was getting wheezy and requiring her salbutamol inhaler more frequently, at least 4 times a week. She was taking budesonide 200, 2 puffs twice daily. She had no significant past medical history. She smoked 10 cigarettes per day, had done so far 2 years. Auscultation her chest revealed mild expiratory wheeze. Examination otherwise unremarkable. Auscultation chest mild expiratory wheeze. Examination otherwise remarkable. Forced expiratory volume 85 وال vital capacity 90.
كده obstructive يعني صح؟ المفروض دي على دي
ما
أنا
هو أزمتك صح؟ هو
asthmatic.
يعني هو أصلا في جايب في السيناريو جايبه لك أزمتك ف
Her symptoms improve and she goes back to tennis without a problem. 3 months later, she was feeling so much better. She decided not to renew her prescription for her inhalers. 2 weeks following this, she developed chest infection and became acutely short of breath. On examination, she is unable to speak for full sentences. Respiratory rate 30 والبلس 115 والبي بي 100 على 60. يعني وقفت لما تحسنت وقفت أسبوعين.
هنا هي كانت تقريبا مودريت وهنا سيفير.
سيفير
أيوة صح دي حاجة السيفير.
تاكيكارديا وتاكيبنيا.
تكبنك صح.
طيب تمام. نشر نعمل اورال ستيرويد ولا
أكسجين وستيرويد
ترافينوس
وإبرة
سلبتامول
ترافينوس.
لا
هو في هاي فلو هو
أيوة هاي فلو الأولى صح. نحن ما
هاي فلو.
لو ما حصل امبروف بعدين ممكن ندي المغنيسيوم سلفيت وكذا.
والأبيتروبيوم هي الأولى مزبوط فيها كل حاجة. After stopping her inhaler, she is no longer on any medication to control her asthma. She presents to the emergency department with symptom and sign life-threatening asthma exacerbation, inability to complete sentences in one breath, respiratory rate أكتر من 25 والتاكيكارديا أكتر من 110 والبيك expiratory volume peak expiratory flow rate أقل من 50. The correct management high flow oxygen with patient pure asthma don't retain carbon dioxide. Salbutamol driven by oxygen, steroid therapy, prednisolone 40 milligram orally if the patient able to take oral medication, or 100 milligram IV hydrocortisone. Abitropium may also be used. Intravenous magnesium should be given in the life-threatening asthma, or if there is no response to initial therapy,